case that I saw a few days ago that I liked because it sort of reminded me of the differentials you might want to think of with pancreas masses. So this person.
Ross, we have a request for you to speak up.
Oh, okay, sorry. This was someone who came in from the outside to our institution, billed as having a pancreas mass. And so I guess
would be a good one to for people to try to give their diagnosis.
Exactly, like if people want to give their diagnosis or differential or what they'd be thinking about here.
How old is the patient?
It is 70 something, I want to say.
Okay.
Is this a grandma?
I don't know her family tree.
They're stranding in the mesentery.
Anyone online aside from Nelly and Gaurav who want to chat in your guesses?
It's really close to the stomach. Do you have the coronals?
I don't, I'm sorry.
So Nelly's thinking maybe from the stomach. Go scroll through. It also looks like it has a claw sign with the pancreas right there.
Yeah, explain the vessels.
Okay, so, Gaurav, Nelly, what do you guys think? I already know the case, so I'm not going to.
Well, I was trying to determine if I'm going to a solid versus cystic category here because, and the reason I asked, anytime I've seen a very sort of heterogeneous, quote unquote, solid lesion like this, serous cystadenomas can mimic solid lesions sometimes, but at the same time, I'm looking at this here and looking like it's invading potentially the splenic vein, so. Might not be that certain about this being a serous cystadenoma. Can we see?
It's not hypervascular, but neuroendocrine tumors can invade the vessel.
Right.
Can you keep scrolling? Can you keep scrolling, please?
Yeah.
Yeah, and Rupa has guessed a non-functioning neuroendocrine tumor, which I think is a great possibility. And then Alina said non-epithelial tumor. Other people say SPEN, and then someone said SPEN, but the age does not fit.
Right.
Yeah.
SPEN, the age does not fit.
Ross, so it looks like there might be a tiny calc there.
Yes, we thought so too. This is just a routine scan, so it's a little hard to be totally sure, but yes, I agree.
So calc you can see with neuroendocrine and in the central scar of a solid serous cystadenoma, usually peripherally in a mucinous cystic neoplasm. There's one clue, I think, at the bottom, if you go to the bottom of the lesion. Right there, it looks like there's like a cyst hanging off the edge of it.
Right.
So that means that one, there's no capsule to this lesion, and it has like a little cyst. It's lobulated cyst hanging off the edge, which would be a little bit less common for a neuroendocrine tumor. So
there's also like an acinar variant of pancreatic cancer that happens in the tail and is super aggressive, looking like this.
Yeah, that's great. Those are more common in men, but definitely could be either.
Yeah, so those are all great, and that's sort of what we were thinking, that, something along those differentials.
Biopsy.
Yeah, well, that's my question, because we did something as a next step. I'd be curious to see what other people would have done as their next step, and then I'll show you what we did.
Nelly, would you really biopsy it?
Can you keep scrolling? I'm looking at the stomach, and I'm just like not comfortable with the stomach. There's like an ulcerating thingy. Right there.
Is that true invasion, or is it just abutting, like both the vascular structures and the stomach?
So Nelly's saying she would go for an endoscopic biopsy or something, right? Anything else you can do?
And there's also like nodal metastasis in the portohepatis. Right? Or right there. Yeah.
So there was a node over there.
Yeah, or anterior to the to the portal portal caval region.
I think we sort of passed those. Maybe we're more liberal.
Okay, now we've also got colloid variant carcinoma invading stomach and bowel.
Okay.
So Rupa wants an MRI. Rupa wants an MRI.
I think an MRI would have been a great choice. We did this instead. So we did what Nelly would have done. And these are not the highest resolution of images, I'm sorry, but did endoscopic ultrasound. And you can see a needle coming into this thing here, and they described it as a mass with some cystic spaces. So here they're trying to show one of the little cystic spaces. And the FNA was non-diagnostic. So does that, so that doesn't really help a ton. So then we went and did the MRI.
Ooh, that
And
colloid variant seems a little bit more, you know.
I do have the coronal here also. So, and we thought this was a very pretty case.
Okay, so we've got cystic neuroendocrine, we've got colloid variant.
But there's like, I mean, this looks a lot more like, yeah, microcystic.
Right.
I mean, it looks like a serous adenoma on MRI.
Do you have MRCP images, Ross?
I don't, I'm sorry. I mean, I do obviously, but not available.
But if you go to the bottom, you see all those small cysts, like all of those little guys.
Yeah. So that portal cable node is like just nothing then.
Yeah, I think that's just yeah.
Okay, gotcha.
Just
Oh, it looked like it was like invading stuff, but it's not. Okay.
Yeah, so we called this a benign SCA. She was having vague abdominal symptoms, but not something serious enough to take it out. So they're going to follow this. And so, but to me, it was nice because the CT, it just showed that on CT, while I think those differentials were great, solid looking masses can actually be these microcystic lesions. So MR might have been you might argue MR would have been a better next step to save her the EUS and biopsy and everything.
I mean, but would we all do that? I don't know. I mean, I don't know. Maybe that's what I should.
What?
I don't know. I'd be super nervous about just calling this an MCA and letting it go.
Totally.
I don't think so. Probably head out soon too.
So we've seen a few of these cases on CT that look very solid, and then you get the MR. And the reason I was asking about the MRCP images because those are very, very T2 heavily weighted. And so when you look at the lesion on those sequences, really only fluid cystic type lesions show up. These can even fool you on post contrast. They can look like they have a lot of solid enhancement because of the numerous fine septations. So we've had a few of these that look like this, very bright on the heavily T2 weighted images. They look like they have enhancement sometimes, as you're showing there, and then they actually go to EUS after the fact because we weren't sure, and they've ended up just being these serous adenomas, and we followed them on imaging over time, and they've been stable.
And I think that image right there shows the nice kind of like septations emanating from the central scar. Often if you can't see the cysts like even that well, but you see more enhancement there, that's because the cysts are so small that you're mostly seeing the very vascular enhancing septae. Alina said, did you discount colloid pancreatic ductal adenocarcinoma variant based on the T2 signal? Ross is dodging your question.
Oh,
Yeah, I haven't seen. I know it exists. I just never seen one, so I just want to know what it is about this that made you discount that.
I guess just the what we felt was like classic appearance plus the MRCP and everything else that made us think that it was just benign SCA.
Yeah, I have a good colloid PDAC. I'll bring it next time, Alina. But they can be very T2 hyperintense, but usually have much more nodular actual enhancement in them.
Okay.
This one has like all these like baby cysts and stuff.
Yeah.
Yeah, I think Gaurav had a good point. The MRCP was, I think, very helpful for us to show that it really was just a lot of cystic spaces.
Okay, last question. Splenic vein invasion, question mark.
No, I didn't think so. Let's see if I can.
Probably there's pushing on it.
Yes, there. I think there's some mass effect, but we felt like it was okay.
Cool, great case.